Dr. Raj, I'd like to add my thanks to Dr. Muhammad Hosni and the organizing committee for inviting me to come to this nice course. I don't have any conflicts to declare. My discussion is really following very nicely the first two speakers today in terms of why do we need to do explantation, the indications, what are the results of the explanations, and what are the implications for our teaching institutions in terms of teaching our registrars and residents and fellows how to do these cases. Briefly, the indications, as you heard, were a failed EVAR, or a rupture after EVAR, which I'll discuss a little bit later in this session, or an infected stent graft, or some kind of aortoenteric fistula. The EVARs fail mostly because of proximal distal fixation problems, which again, as the previous discussion, you heard that if you start violating the instruction for use, you're running into issues. And on this picture of a CT scan of a patient that I did about 2 or 3 months ago, this is a patient that had a physician-modified device, stent graft. They created a hole in the fabric of the graft, then put a stent. So basically, it's a back table modification of a graft. The patient presented 3 years after this operation with a dilated neck. The neck now measured 440 millimeters, so there's no graft to fix that. So we had to explant this and then obviously do some cold perfusion to the left kidney and reimplant that. So the complexity of extraction is going higher as we speak. I bring this picture to your attention just to tell you that all the grafts that you see here have been implicated in failure. So there's not one graft that is without failure. Ironically, the Anchor graft is probably the best graft that was ever made, and that has been pulled off the market by Guidant, and that may be something that we can discuss a little bit later. But what I want to focus on is when you do these explantations, do you have to do a suprarenal or supraceliac clamp? Do you approach a transabdominal or retroperitoneal? And then what do you do when you have to perfuse the kidney? Dr. Tawfiq said that he took out an ovation graft, and this is probably the biggest nightmare in terms of having these stents go all the way up to the SMA, making it incredibly difficult to remove. I've had the pleasure of explanting Zenith stent grafts, and I can tell you that it's not an easy operation, and that you have to use some tricks to facilitate this. And one of the tricks that maybe will come up in the discussion is to use ice-cold saline on the nitinol part to try to get the stents to shrink. The issue will always that you encounter during the operation is, should you leave any graft behind and sew your new Dacron graft to some portion of the old stent graft? This is a paper that Dr. Macroon mentioned, and I think this is the most up-to-date reference in the literature that discusses open conversion after endografts. And I want to summarize a couple of points here. One is that the incidence of explantation is going up, as you can see. We need to be able to train our registrars to do this. The indications are for non-ruptured aneurysms, but there's about a third that are for rupture or infection. The results are, this is first, the aneurysm size that gets operated on is pretty big, average of 7 to 7.5 centimeters. And these are the results. I think Dr. Tawfiq earlier mentioned 20 or 30% mortality. I think the mortality can be up to 40%, and you can see on this slide that with infection and rupture, the mortality approaches 40%. It's still high for unruptured elective cases. The 30-day postoperative, this is the summary of length of stay in the hospital. It's not an easy operation. You have incidence of other complications, including acute kidney injury and ileus in these patients because of the extent of the operation. And then finally, the overall survival is not the best. Over a period of about 7 years, roughly a third of the patients are dead. So getting back to this case that I showed you earlier, you can see here that the stent graft is essentially unopposed to the aortic wall, and you have a renal stent hanging out in the breeze, and you have to do a suprarenal or supraceliac clamp to get control, then remove the graft, and then put your new graft in and do a renal bypass. I show this case just because this was an endologics case. One of my partners had done it, type 3 endoleak, and I spent about half an hour trying to get back into the scrunched limb, and the final result here shows that we were able to avoid an explantation, but I kind of wonder at night how long is that going to be good for. So to summarize, endograft explantation is on the rise in my practice, and I think overall everywhere in the United States and Europe. It's a technically very difficult operation. I think I emphasize what the previous speakers have said. You need to plan for this very carefully. Your mortality rate is going to be in excess of 30 to 40%. And the biggest fear that I have is that our junior registrars are doing 80 to 90% of their elective aneurysms are done with an endovascular procedure, so their exposure to open aortic surgery is going down. And we need to find a way to train these people on easy cases before we throw at them a complicated case, which I doubt in my shop they will get to do much of. Thanks for your attention.